Good morning from Colombo, Sri Lanka. This is Dr. Megha Ganewatha representing the Health Informatics Society of Sri Lanka. I'd like to welcome all of you around the globe for the special A in our G2MC Grand Rounds. Rapid advances in genome sequencing technologies, bioinformatics and computational biology is heralding in an era of genomic medicine. This series of lectures conducted by the Global Genomic Medicine Collaborative G2MC, supported by the Health Informatics Society of Sri Lanka and the Asia eHealth Information Network, will showcase some of the pioneering initiatives in genomic medicine from around the globe. The series would be co-hosted by Prof. Bruce Kopp from University of Alabama in Birmingham, United States, and Prof. Vajira Disanayake from University of Colombo, the co-chairs of the Education Working Group of G2MC. Before moving on to today's session, I'll briefly mention few things to remember while using WebEx platform. Once you have logged into WebEx, the left panel is where you shall see the content presented by the panelists, including PowerPoint presentations, videos, etc. The right panel contains some useful tools. If you click on the participants icon, it will display all panelists and attendees currently logged into the event. Q&A button can be used to ask questions from the panelists. You can also provide feedback during the presentation by clicking on applause, yes, no, too fast, too slow, and laughter buttons. Please note that your microphone will be automatically muted once you join as an attendee. If you encounter any issues in receiving audio during the webinar, please log out from the WebEx platform and try to re-log in. With this brief introduction on WebEx, I'd like to invite our resource persons for today, Professor Ryan Wu and Professor Laurie Orlando. Professor Ryan is an Assistant Professor of Health Service Research, Precision Medicine Institute, Duke National University of Singapore Medical School, and also an Assistant Professor of Medicine at the Center for Applied Genomics and Precision Medicine, Duke University. Professor Laurie Orlando is an Associate Professor of Medicine and Associate Director of Precision Medicine Program of the Center for Applied Genomics and Precision Medicine, Duke University, Durham, North Carolina, USA. Over to you, Professor Ryan.
Good morning, good afternoon, good evening, depending on where you are in the world right now. Today we're talking about using precision medicine to improve risk assessment. So why is risk assessment important? There's been increasing use of risk stratification within clinical guidelines. If you look at NCCN guidelines or the more recent cardiovascular risk calculator, these all use risk stratification both to determine appropriate treatment for a given condition or to understand the patient's risk for developing a condition. And risk assessment incorporates multiple data elements to synthesize a global risk. So, for example, in familial hypercholesterolemia, you have to include your family history, the clinical history of the patient, the physical exam, and the lab values, all to understand comprehensively what that patient's risk for the condition is and whether genetic testing is appropriate or not. The reason it's important to use these types of tools is that you can improve both the personal health for that patient as well as the population's health by focusing efforts on patients who are most at risk for the target condition and targeting the treatment for the right patients at the right time and to maximize the benefits over the harms. An example would be breast MRI used as screening for breast cancer. So we know that breast MRIs increase the detection of cancers, but they also increase the frequency of biopsies, both biopsies of what ultimately becomes a true cancer and false positive biopsies. So to decrease the likelihood of unnecessary biopsies, guidelines recommend that a patient's risk of breast cancer be over 20% based on their clinical and family history before you consider using breast MRI as a routine screening mechanism for breast cancer. In the current state of risk assessment, several different data points need to be considered, both the family history as well as the clinical data for the given patient. And these both factor into the risk assessment for the given condition or for the given outcome of the disease that's already developed. Family health history can be considered as a test case for precision medicine. Francis Collins, the director of the NIH, has referenced family history as being the first genomic test. And it's a good first step in the use of genomics and precision medicine within healthcare because it's widely accepted by the medical community. It's seen as an essential element of clinical care, even though evidence suggests that we don't often use it in the best way, in a way that maximizes its utility for the care of our patients. Family history is relatively easy to collect and at a low financial cost, and there's numerous guidelines supporting the use of family history that provide clinically actionable recommendations tied to what the patient's family history is. So these risk assessment tools have been developed, particularly ones relating to the use of family history. There's been several that have been developed over the past few years, and looking at what the global risk for various conditions might be for patients based on family history and clinical data. And we found that even within a general population of healthy individuals, that when they use one of these tools that we'll discuss in a little bit more detail later, 42 to 82% of the patients are found to be at increased risk for at least one of the conditions that they're evaluated for. These are patients who were not previously identified as being above population risk. But after use of this tool, if you apply current clinical guidelines, you'll find that a significant number would qualify as being at elevated risk. In addition to using the tools and improving the identification of those at risk, using these tools increases referral for closer surveillance or genetic counseling for high-risk patients. This has been documented with the use of one of the tools, MeTree, which we'll talk about more detail later, as well as Hughes risk apps. We've shown that when patients are identified at high risk, you can change the behavior of the patients and the providers such that you refer these patients on to get the appropriate surveillance that they need. And in addition to changing the behavior of the high-risk patients, there's also been documented evidence of decreasing use of high-risk services among those who are average risk. So with the use of a tool called MeTree, there was an 81% decrease in the use of high-risk services for average risk patients, things that they were doing before that maybe based on guidelines weren't really indicated, and they stopped doing after receiving a risk assessment report. So what exactly are they getting identified as being at risk for, and what are the recommendations that they're being given? So in one example, in a healthy primary care population in the United States, when you put them through one of these risk assessment tools, 26% of the patients were shown to have a risk that would be concerning for hereditary cancer syndrome, and guidelines would recommend that they would receive genetic counseling for assessment of that risk. In addition, about 10 patients, so about 1.5%, got recommendations for breast MRI for more aggressive, more close follow-up of screening for breast cancer. Almost 10% got recommendations for chemoprophylaxis to decrease the risk of breast cancer. In regards to colon cancer risk, there was a significant number that received recommendations to either start colon cancer screening early or to move to more frequent colonoscopies. There's also a small number who get referrals for screening for ovarian cancer or thrombosis testing or counseling based on their family history or their own personal history. So we can see that you can identify patients who are at higher risk using these tools, and we can change their behavior, but how accessible are they by the general population? Are patients interested in it? Are providers willing to adopt it? So in publications after use of these tools, there's been shown that there's no increase in anxiety related to risk assessment results. There were some hypotheses that this would cause undue anxiety among patients, but that hasn't been shown to be true. And in addition, providers who oftentimes were initially hesitant about using these tools and thought that they would disrupt their workflow and that they were doing a sufficient job at assessing their patient's risk using their family history, after use of the tools, found that it didn't disrupt their workflow, it made their practice easier, and in fact felt that it helped improve the care they were giving their patients. In terms of the usability for patients, there's no impact on the perception of usability based on race or education level of the patients. And patients are interested in these kind of tools. For example, there's a health system in the United States called North Shore Health, which put one of these health information risk assessment tools on their patient portal. The tool they put on it was Health Heritage, and they put it on the patient portal, which is the place where patients go to check their lab results or make appointments or email their doctor. And they didn't advertise it. They didn't point patients to it to say, you should go fill this out. They just put it on the portal and found that significant numbers of patients were voluntarily going in and filling this out because they want to understand what their risk for these various conditions were. So we said that in the current state of risk assessment, family history is an important aspect and clinical data is an important aspect. But as we move into the era of precision medicine, how does genomics play into this? We know that there's genomics and clinical data and family history all interact with one another, and the interpretation of each of these elements is affected by what the other elements are. And all three of these should be playing into how we do risk assessment for patients. We know that genetics impacts your phenotypic risk and how you interpret a patient's phenotype. So for example, a patient who possibly had a family history of colon cancer, their risk of developing colon cancer themselves is going to be higher than the population on general risk of developing colon cancer. But if you then take that patient and you do genetic screening and you were to find that they had Lynch syndrome, that risk increases to up to 80%. So having a genetic test done affects how we interpret their family history. For the patient who didn't have that Lynch syndrome result, their family history tells you something different. In another example, there was a recent study done looking at the clinical utility of adding a genetic panel to standard clinical and pathologic criteria for selecting patients for adjuvant chemotherapy for early stage breast cancer. And what they found was that for those patients who had higher risk clinical and pathologic features, but a lower genetic risk based on the genetic panel, that those who did not get chemotherapy, who are randomized to not get chemotherapy, did just as well as those who got chemotherapy, and in terms of their survival without metastases at 5 years. So even though their clinical and pathologic staging would indicate a high risk, if the genetic scores showed that that was possibly not the case, you could forego chemotherapy in those individuals. Now, I would argue you need to go a step further than that and not just saying genetic testing can circumvent or trump what the clinical and pathologic staging say, but how do we include both together in understanding the patient's risk? How do those two factors interact with one another as we do risk assessment? In the same way, the phenotype impacts our genetic risk. So there's a variant called PALB2, which is commonly known to be associated with breast cancer. And if you have a PALB2 variant, but no family history of breast cancer, your risk of breast cancer before age 70 is 33%. That same individual, if they have 2 or more first-degree relatives with breast cancer, the risk goes up to 58%. So it's not a black or white, you have the mutation or you don't, but even in the interpretation of that mutation, you have to look at clinical factors and family history factors that could interpret how we assess that patient's risk. In the same way, BRCA1 and 2 are associated with a lifetime breast cancer risk of 45 to 65%. And that's a significant difference at the top and bottom of that end of the spectrum. What is it that's driving that difference? There's more to it than simply having the genetic variant or not. But what are the other factors, environmental or other genomic factors or family history that we need to consider in understanding where a patient lies within that spectrum? There was an interesting project done by a company called Counsel. They offered free breast cancer risk genetic testing to women in San Francisco, in Western United States. They offered free testing to any woman, didn't matter what the patient's risk was, to see where they stood. And over 2,500 women within a 3-month period signed up and got genetic testing done. What was interesting is that they found that 4.2% of those patients who are just general healthy population tested positive for at least one variant that would put them at increased risk for breast cancer. That was higher than we might have expected based on other data. But I think what was more interesting even was that almost half of those patients who tested positive did not meet NCCN criteria for genetic testing. So either there's something else that is driving it in addition to that genetic variant that needs to be considered, or we're missing something in their clinical or family history that would guide us towards doing genetic testing in these women. In the same way, variants of unknown significance can be considered. Currently, as we interpret these variants We can look at the patient's clinical data, and there may be a little bit of family history available, or we look at what's already been reported in the literature to understand what those variants might mean. But there's been a movement towards emphasizing having greater amounts of clinical data and detailed family histories available as you make interpretations of these variants. How does the patient's family members and the conditions they have, how does that help you to understand what the variant might mean and how it might be interacting or working in the patient? So as we said, risk assessment currently involves family history and clinical data. That genomic data needs to be included in that consideration. And then also environmental data, and that all four of these areas interact with one another. And not only do that you need to consider each one, but what each element shows is affected by what the other elements show. And then all four of these need to go into what we do in risk assessment. Some work that our group has been doing in understanding that better is looking at pedigree analyses. So we have 2,000 to 3,000 very detailed family history pedigrees in our database. And we're using social networking analyses to understand relationships between conditions across the generations. So how can we understand that a family member having cardiovascular disease affects this patient's risk of diabetes? So that when I'm taking a family history, I'm not just looking for one condition, I'm looking for a spectrum of conditions that might cluster together and all point towards an elevated risk. And then once you understand those disease clusters, how could we quantify those relationships and understand the genetic underpinnings of the disease? So for example, we know that there's some connections here between cardiovascular disease and diabetes and stroke, and that having one increases your risk of having another. Same could be said for some of the cancers. But what are some other conditions that maybe are a little less common, that because they're rarer, we don't see those connections as easily? And by doing large pedigree analyses where you can pull in lots of family histories from multiple generations, we can start to pick up on diseases that maybe have some similarities or heritability that ties them together. In Singapore, we are collaborating with Duke to develop a large healthy patient cohort within Singapore that pulls in clinical data on the patients, very detailed family histories using the MeTree tool, and also does whole genome sequencing on these patients. And then we're following those patients for 10 years. And the idea is that we can then use all of that data to understand how these different data elements interact with one another and how they contribute to the patient's risk. At this point, I'm going to turn over the presentation to my colleague, Dr. Orlando, to talk more about the real-world implementation of tools like this as they currently stand.
Thank you, Ryan. Can you hear me?
Maybe turn the volume up a little.
Okay. All right, that's as much as it goes. Okay, so as Ryan said, I am going to talk a little bit about how you can take all of this information and try to pull it together into something that's clinically meaningful and actually can be applied in the context of a clinical visit when a patient's coming to see their provider. In the U.S. and in many countries in Europe, we have fairly strong primary care systems. And in those systems, we're supposed to be doing preventive care and risk assessment to determine what types of preventive care might be most useful for an individual patient. That's difficult. There's a number of reasons why, and they fall across the spectrum of stakeholders. So for example, if you're thinking about family history, the patient is the source of the family history, but they frequently don't know what their family's medical history is. There's often a single person in a family that's sort of the keeper of the information about the family, but it's often not the person that you're seeing at the time of the visit. And since they didn't know that they were going to be sharing that kind of information, they often haven't gathered it ahead of time. There's also a lot of confusion in the lay people about different types of diseases. So for example, the differentiating something like an arrhythmia from a heart attack is very complex. It's easy for medical individuals to understand, but not so much for the community, often they just lump them all together as heart disease. Or, for example, the differentiating, uterine cancer from ovarian cancer, a very big difference when you're thinking about risk and pathology, but not so different when you're not entirely well-versed on the different organ systems. So, the patients are a significant barrier often to collecting accurate information. The second area is providers. The providers, especially in primary care in the U.S., have very little time, and almost all of the care that the preventive task force recommends be applied to patients is meant to be done in a primary care setting, but with the current reimbursement strategies and limitations with time, it's very difficult for a physician to actually collect that information from a patient. They also are very complex. Most of the risk algorithms don't involve simple adding up a couple of different risk factors and then saying, okay, scores between 0 and 1 are this, and 2 and 3 are this. It's logistic regression equations, something that clearly can't be done at the point of care. And the different risk calculators, when they are electronic, are often in multiple different web addresses and such. And so, again, not an easy thing to navigate during a clinic visit. So the provider and the patient both have real difficulties in being able to do this. And the health system has really done little to support them in that effort. So health systems could really use the electronic medical records and data collection and lots of educational tools to help facilitate this process, but they really haven't been able to rise to that challenge. And so it's sort of languished a great deal and has been sort of deferred to third-party systems to try to develop a solution to this. And so, Ryan, next slide. One of the best tools to be able to bring all of the different barriers into line is to develop an IT system that's web-based. And the reason for that is that the patients can interact with the system directly, where they can receive the education that they need. They can receive counseling to go talk to their relatives to get the accurate information and enter it in the tool so that it doesn't need to be collected at the point of care for the physician. And it can create automated risk calculations and clinical decision support so that the physician doesn't need to be able to synthesize all of that information at the point of care either. And by doing that, it allows both the patient and the provider to create kind of a clinical decision support that's tailored to each so that they both understand what the options are, what the risk level is, and how to talk to each other about the various strategies for moving forward and what's most in line with the patient's values. It can also help the health system by bringing all of this data into the electronic medical record, and by embedding that clinical decision support in there, it can facilitate population management. It also requires data standards for different health systems to be able to communicate with each other and for risk assessment to be adopted widely. And we now have emerging standards that are able to create those data standards. So largely the HL7 movement initiated this, and there have been several iterations of the HL7 movement. They're now on the third version. And FIRE, which I will talk about in just a second, has leveraged this to really bring about a revolution in the way that we can interact with data. Next slide. So there are a number of tools out there now that have been made available to do risk assessment, most of them in primary care, not all of them. And they all have a variety of approaches that they've taken. So Mitri, that Ryan alluded to earlier, was developed at Duke and does currently risk assessment for 80 different medical conditions. It's completed by the patient at home through a web interface and provides clinical decision support for the patient and for the physician. It also is integrated with the electronic medical record. There are other tools such as Family Healthware, which is the fourth one on this table, is also electronic and integrated with an electronic medical record. is completed by the patient, though, and only provides information back to the patient. It was never designed specifically for physician reports. And similarly, Hughes Risk Apps, which is about halfway down there, was designed more for physicians to be completed by genetic counselors when a patient was in their office. So each one is slightly different. Health Heritage, the one just below that, also was designed for primary care, is integrated with electronic medical records completed by the patient, and it was optional for the patient to share the information with their doctor if they wanted to or not. So each of them have taken a different approach, but the fact is that there's been a wide proliferation of new tools to help look at this barrier, understanding that it was a significant problem that needed to be solved by people outside of the healthcare system. All right, next one. So MeTree, as I said, was developed in Duke, so I was one of the lead developers on this tool, and we've conducted several research studies to look at how it performed in primary care populations to meet the needs of the stakeholders, so including assessments of patients and providers and the healthcare system. So these are some screenshots of the tool itself. The patient, when they log in, would see a screen like this, where they start to fill out information about themselves. Next slide. And these are the variety of information about themselves that's related to some of their personal risks. So this shows some conditions on it. So they're organized by organ system, and when you choose a condition, you then get this drop-down box that shows you to the age range of diagnosis so that we can use that information in the risk calculation. Next slide. And when you get to the point where you're done completing the information for yourself, you can begin to fill out a pedigree. So this uses a tablet, drag, drop, swipe solution to build a pedigree. So you just pull the icon over and drop it on the bar that's appropriate. And then you identify who that person is linked to in the bar just above it. So in this way, you can build a very large pedigree within just a couple minutes. Next slide. And at the end, when they're done entering all their information, they get a pedigree like this, which shows you the proband there with the arrow, and then all of the family members that they've entered, as well as the conditions and the age of onset for those conditions, using standard pedigree nomenclature and annotation. Next slide. This is an example of some clinical decision support that's provided to the patient. So in this case, you can see that it's organized by screening and lifestyle, and there's a couple of other options below that, but so some examples of something text that the patient might get would be to talk to your doctor about regular colon cancer screening, or talk to your doctor about the Framingham risk calculator, and that they did not have information to complete that risk. So if they wanted to have their Framingham risk calculator run, they know here that they need to be able to enter their blood pressure or their HDL cholesterol and their LDL cholesterol, so they can then either track that information down or talk to their doctor about collecting that information so they may enter it and understand what their risk is. Next slide. So once you have a tool like this, it's very useful, but is not going to be successfully integrated into a clinical care unless it's actually integrated with the EMR that the physicians are using in the point of care. There's lots of data now that no matter how useful the tool is, if you have to go somewhere else to get information, physicians just aren't going to do that. So how do we to overcome that barrier? And as I mentioned earlier, there's some data standards now that derive from HL7 that can overcome many of the barriers that exist. So one, it's standards-based. It's using modern technology that's used by Google, by Facebook, by lots of different existing technologies that are widely used in the community but aren't largely used in the healthcare system. But it takes those standards and applies them into healthcare, and now and then creates APIs to be able to move the standard data back and forth from the healthcare system into this third-party web service. It also allows authentication to occur seamlessly. So a patient can log into their electronic medical record through their patient portal and then be taken directly into the tool. The tool can then use the APIs to pull data from the electronic medical record that needs to be used in the risk calculations and pre-populate those fields in the web service. And then the provider can, at the same time, see all of that information within the patient's chart in the EMR. Everything that's generated by the third-party service will be displayed in a window within the EMR without the provider having to do anything other than log into the patient's chart. One of the nice things about FHIR and SMART is that there are no license fees. It's free, and HL7 initially charged, but that recently they've stopped doing that. However, there are some cases in which people are still charging. Next slide. And then this broad acceptance from the third-party developers as well as the large EMRs, that this is really a necessary step forward to make clinical care significantly better. And so they've now started to accept this, and they've actually participated in multiple projects now, including the Argonaut project, to help develop the standard so that most of the major EMR developers like Epic and Cerner and athenahealth are now all supporting this standard. Next one. So as I said earlier, with the standard, a patient can now log into their patient portal and then click a link which will take them directly into the third-party service tool, in our case it's Mitri. And then the Mitri will communicate with the EMR. It can pull the information that Mitri needs, as well as once Mitri is done running its risk calculators, it can push information that's generated in Mitri back to the patient's EMR. So for example, if the patient enters information about their family history that doesn't exist in the EMR, it can push that family history information to the EMR. The patient will enter any additional data that needs to be entered, and then they get their patient-oriented report. So all of this simplifies the process so that once the patient goes to the visit with the provider, they've already entered their information, received their report, and the provider has their report in the chart, and everybody is prepared to have a discussion about what information the report indicates is appropriate for that patient. Next slide. So this would be the provider workflow. You can see it's quite a bit simpler. They log into the EMR, into the individual patient. They can now just click a tab in the window, which will create a applet with multiple views of the data that's been entered, as well as the results of the risk calculation and the clinical decision support. Also, the EMR will always contain the most updated information when you do this type of workflow. So if the patient goes back and enters new information at any point in time, the physician can just log into the chart and will immediately see all of the most updated information. Okay, next slide. Okay, so that is the mechanism by which we envision most of the risk assessment tools and other third-party web services now being able to leverage the new innovations in the health IT world in order to be able to integrate data that's complex. I mean, family history is difficult enough, but genomics, when you start bringing in genomics and environmental data, these are things that need to be collected and interfaced through a automated process in an IT system and always kept up to date. So thank you, and we'll take any questions.
Thank you. Informative, elaborated session from Ryan and from Laurie. We can now move on to a brief Q&A session. Please use the Q&A box on your right panel to type in your questions. We'll try our best to accommodate all the questions. Prof. Ryan, actually, we have about 3 questions. Are there any implementation of the technologies and tools you mentioned in developing countries?
That's a good question. I know of some work being done by the George Institute that Duke and US is involved in that's using information technology tools to provide clinical decision support to community workers to screen patients for cardiovascular disease, diabetes, and things of that nature in the community and refer them on to clinics for care if they're found to have a condition. That's the only one I can personally speak of. I'm sure there are other tools out there like that being used in those settings.
Thank you, Prof. Ryan. Are there any plans to extend your work to other countries? Any future plans?
Yes, so we've already started developing collaborations with Duke and US in Singapore. So we're bringing Mitri, the family history tool, into a project that they are doing in their Center for Precision Medicine so that we can tie in genomic, family history, and clinical data to understand how those interrelate better. Lori may be able to comment on other countries. I know she's had some interest from other places about the tool. So.
Yeah, so we've had discussions with actually 3 or 4 different countries. They're all fairly unique in the type of populations that exist within them. So, for example, a couple of Middle East countries which are fairly small and have very homogeneous populations. In Canada, and particularly Quebec, which is very heterogeneous and French speaking. Currently, we actually have the tool translated into English and Spanish, but have plans to translate into other languages as well. So French, for example, would be a simple one, whereas Arabic would not be quite as simple. But we do intend to continue those discussions with other countries and to try to accommodate them. The biggest challenge is differences in how risk assessment is performed in those countries. So not currently the tool is based on the recommendations that are made in the US for how you calculate risk and what you do to mediate the risk in an individual patient. It's not the same across countries. So being able to accommodate differences in language and differences in countries is a challenge, though certainly something that we think is worth investigating.
Thank you, Prof. Lori. The next question is, how costly and feasible would be a project to integrate all these functionalities into an existing legacy EMR?
That's another one for you, Lori.
Yeah. So it would really depend on the capabilities of the legacy EMR. So if that EMR was able to easily be adapted to accommodate the new data standards, I think it would be very easy. That's one of the wonderful things about the new technologies is that they're based on data standards that are already being used widely, as I said, in Facebook and Google. So a lot of people are very familiar with those standards and are using them in other countries. If the capabilities to adapt that type of interface existed with the legacy EMR, then the actual building of the connections between a web service that could offer risk assessment and genetic integration and all of these pieces of data and an EMR would be very simple. But I think the question would really hinge on what that legacy EMR looks like.
Thank you, Prof. Lori. Moving on to the next one. If we don't have HL compatibility in an old EMR system, what should we do? Going for a new one, or if there are any examples integrating all of these into the existing systems worldwide? Shall I repeat? If we don't have HL7 compatibility in an old EMR system, what should we do? Then he asks, going for a new one, or if there are any other examples integrating all of these into existing systems worldwide?
Yeah. So there are examples of places where they have custom-built systems to integrate all of this data, and where it's worked reasonably well. I think I certainly wouldn't want to say to someone that they had to get a new EMR, and that's quite expensive and a huge challenge and a many-year challenge and quite costly. So I think it would really depend on what your reasons were for wanting to be able to use the data, and if it were simply to help improve your healthcare system and you had no interest in interacting outside of the healthcare system, and the healthcare system had some rudimentary data capabilities, I think it certainly might be simpler and less costly to try to build it yourself. But it really does kind of matter what the goals are.
And these systems, these IT tools can be used without the integration with your EMR. And that's the ideal, to be able to have data that flows in and out and updates the EMR and vice versa. But most of these tools were tested in environments outside of an EMR. So it was just the tool itself, and it provided a report, and then that was scanned or uploaded somehow into the medical record. So it's possible to use these kind of risk assessment tools without the EMR integration. That's just the goal. That's the ideal eventually.
Okay, thank you very much. Next one, if we extract data from an existing EMR, what level of privacy we should look at?
Yeah, so the new standards, the authentication is what's important there, as well as where the data is stored. In the U.S., we have HIPAA, which determines for us data storage and how data is shared. And the authentication standards that are part of the HL7 and FHIR and SMART environments they all meet those requirements for the U.S. I'm sure it varies according to country, but I would guess that at least the authentication and the data security that's built into FHIR and SMART would be acceptable to most countries. The requirements for where the data is stored may vary, though. So, for example, whether there is a cloud-based system that would be acceptable to another country, or whether it would need to be something that's hosted by the health system behind their privacy wall, would vary, I think, depending on the country standards for privacy. The other thing to take into consideration in terms of privacy is the sharing of data amongst family members, and whether genetic data and family history data results can be merged to understand risk amongst and across family members. In the U.S., that's not acceptable at the moment, but in other countries it may be more acceptable, because that information is very valuable in determining an individual's risk, and family members may be able to agree to have their data shared amongst the family.
Okay, we have one more question. On ethical context, how feasible and what are the patient's opinion on extracting data to predict sensitive diseases? Are there any research done on that?
Well, if it's for themselves, then what we found is that they have absolutely no concerns whatsoever. In fact, there was a great deal of debate about whether patients would find genetic testing anxiety provoking, whether entering family history into an online web-based tool would be anxiety provoking. And we found that in general, they feel like this is all about helping inform their personal health, and so they have no real concerns about having the data, entering the data in those systems and having it used to help predict their disease.
Thank you, Professor. Before concluding, are there any remarks for two of you to make?
No, I don't think so, Lori.
No, I mean, I would just say that I think that in the world of precision medicine, there's been a lot of attention paid to genomics and the results of genetic testing. And I would just like for us to remember to take a step back and look at the big picture. And genetics by itself is not going to answer all of the questions that we have about how to care for our patients or individuals in our countries. I think it's really important for us to remember that family history, environment, all of this clinical information needs to be merged together and looked at as a whole rather than as individual diseases or as individual pieces of data. And I think that there are several initiatives out there that agree with that, such as the Precision Medicine Initiative in the U.S., but in a lot of places, a lot of emphasis is placed on genomics alone, and I think that we need to remember that these other pieces of data are just as important.
Thank you, Professor. Since there are no further questions, we'll be concluding the G2MC session for today. I must thank the resource persons for today's G2MC session, Prof. Ryan Wu and Prof. Laurie Orlando, on behalf of Health Informatics Society of Sri Lanka and the Asia eHealth Information Network. And also my sincere gratitude extends to Ms. Charis from AHIN Secretariat and Dr. Jayatri Vijayaratne, who is currently with me coordinating this session from Sri Lanka. We'll be meeting again next month during the 6th G2MC session. Until then, bye-bye from Colombo.
Thank you.